tarsal coalitions. So what foot deformities often occur rather, as a result of tarsal coalition? Who remembers? Pronation, absolutely, right? Essentially because of presumed anatomical variation or absence of the ligaments that make up the medial structures. Okay, very good, very good. All right, guys, here we go. So moving on. Okay, metatarsal fractures. All right, metatarsal fractures, right? These essentially can be either traumatic. These can occur obviously via direct trauma, right, or via microstress. So like presentation like stress fractures. Let me actually maximize or go full screen here. Sorry. Okay, so these can actually obviously also occur as I was stress fractures more commonly via direct trauma. In adults, okay, in adults, the fifth metatarsal is the one that is most commonly fractured. Okay, and you guys are going to see this a lot, particularly in your court sports, volleyball, basketball, and those populations. You guys, and even in your soccer players, you guys are going to see a lot of these fractures because these sports involve high levels of running, jump stopping, and force being transferred through the foot, right? In little kids, we see a lot of fractures of the first metatarsal. Whoops, I made a typo. Guys, sorry. Fix that right now. All right, fixed. Okay, yeah, ultimately in children, we see fractures of the first metatarsal quite a bit. That can happen, right? But anytime you guys see fractures to the second through fourth metatarsals, those are generally going to occur as a result of direct trauma, right? Or they're going to present to you like stress fractures. All right, so you may have someone come in that points, directly to one of to a metatarsal and says, yeah, my foot hurts right here, and they point directly to the bone. Okay, and generally, if we're talking about second through fourth metatarsals, we need to either be, essentially cognizant of a stress fracture if there is no traumatic, injury or mechanism that they present with. The other thing that we need to keep in mind is that ultimately, if something is fallen directly on the foot, be it a weight, be it something heavy, whatever it is, maybe they got stepped on, right? This can also result in obviously fracture to the metatarsals second through four. Okay, but what about the fifth metatarsal? Okay, the fifth metatarsal is, if I'm going too fast, stop me, I can back up. Okay, the fifth metatarsal is different. Okay, and the reason why it's different is because we have different injuries that can occur in different zones of this bone, right? If you guys remember, I told you that we have, and I'm going to do a little bit of drawing here, but we have a tendon. Whoops, we have a tendon. Okay, that actually attaches on the base of the fifth metatarsal, right at the styloid. Okay, who remembers that tendon? We're going to talk more about this when we talk about the ankle, obviously, as well. But who remembers? What's the name of the tendon? We have a group of muscles that comes around the outside of the lower leg, form a tendon, and attaches right on the tuberosity or styloid of the fifth metatarsal, just like that. Okay, you guys see that? Okay, so ultimately, right, these fractures can occur in either zones 1 through 3. So, gosh dang it, my brain is still not working correctly, you guys. I'm so sorry. So the fractures that occur in zone 3, all right, that's the diathesis, and I'll make that correction here. Okay, those are often stress fractures. They happen as a result of repetitive loading of the bone, right? So people that are running a lot, jump stopping frequently, may begin to develop stress fracture type pathology within the metatarsal. Okay, now right in between the diathesis, right as the metatarsal starts to essentially branch into kind of the base from the shaft, right? The area between the tuberosity and the shaft is known as zone 2, okay, and or essentially the metaphyseal region, right? And that's where Jones fractures can occur. All right, generally speaking, these are most often related to forces like jump stopping and or stress fractures from running and those types of things. Okay. Conversely, fractures that occur in zone 1 at the level of the tuberosity generally occur secondary to an ankle sprain, right, or some sort of forceful inversion of the foot or plantar flexion of the foot. The reason why that happens, guys, is when the ankle forcefully inverts during a sprain, the tendon here, okay, that I've drawn on the slide lengthens, right, so that the tendon actually creates essentially a pulling force on the tuberosity and can avulse the tuberosity away from the rest of the metatarsal when the ankle inverts or forcefully plantar flexes. Okay, so as the ankle rolls over, the tendon essentially forcefully lengthens and can pull bone right off. Okay, so if we look at the bottom picture, okay, this is actually this is a picture of a Jones fracture right here. Okay, the way that this would typically be managed, it's not really a lot of widening. This could probably be treated in just a walking boot. So the patient could be placed in a walking boot for about 4 to 6 weeks, and this allowed to heal. In the event that it did not heal or the patient continued to have symptoms, you could consider placement of a cortical screw to fix that. Can you guys hear me okay? Is my sound being wonky?
You're good. No, you're good.
I'm good. Okay. Hey guys, give me 1 second. My dog needs to go outside. Sorry, guys.
I think it's saying that diaphyseal is the type of stress fracture, and the diaphysis is the location.
So, but that's not
Oh, yeah, zone 1 is the
zone 1 is 2 grams. Okay.
That's a good one.
All right. Okay, guys. So obviously, fractures at the metatarsal divided into either fractures at zone 3, the diaphysis, okay, zone 2, which is essentially the area right between the tuberosity, right, and the diaphysis or the shaft, right, and then you can have an avulsion of the tuberosity with either forced inversion or plantar flexion. Okay, does that make sense?
Yeah.
Okay, good deal. Good deal. Good deal. Oops, I'm gonna take clear all the drawings. Cool. All right. Okay. Now here's the deal, guys. Okay, it's really important. Really important to learn how to differentiate when something might be a stress fracture as opposed to a traumatic mechanism. All right, because these are going to present to you differently. Okay, this is going to present to you very differently than maybe a traumatic fracture, right? So ultimately, someone who presents to you with the possibility of a stress fracture is going to tell you that they've had, essentially maybe repetitive stress, maybe, and this is generally related to a history of microtrauma. Okay, what's an example of that? An example of repetitive microtrauma is somebody who runs, however many miles a day and begins to notice gradually increasing foot pain and or maybe even shin pain when we talk about the lower leg next week, right? But continues to run and repeats the same pattern of microtrauma or microstress to that bone over time. Okay, now here's the deal. Key points in the history that you guys are going to need to be aware of and listen for is they're going to tell you, okay, yeah, I started running or what have you, or I've been doing this for a few weeks and I didn't really run all that much, but I just started up again and I've been running about 3 to 5 miles a day. But I've noticed over the course of the past few weeks that my foot has started to really hurt, right? It started to ache and the pain has just gotten worse, right? So what you hear generally is a longer presentation or progression of symptoms, right? And pain generally increasing over time, right? So those symptoms typically begin as dull symptoms, but gradually become more focused. So if you guys remember, we talked about this really briefly in intro, okay? What's one of the key things, like when someone's progressing from like just general like periosteal inflammation to a stress fracture, what's another thing that they might tell you? What's another thing they might say to you? So so if you guys remember, in like the first day or second day of class, Charlie, I think it was Charlie, gave us an example of a guy who was doing a lot of running, right, and was having shin pain. And if I remember correctly, Charlie, correct me if I'm wrong, that case actually ended up being like medial tibial stress syndrome or shin splints, okay, to use a colloquial term, right? Now, how does shin splints kind of differentiate from a stress fracture? What's the different clinical characteristics between those two? We'll use this as an example.
Shin splints is in like concentrated in one area, while a stress fracture will be up and down the entire shin.
Okay, so Charlie, it's actually the other way around. Okay, I like the fact. No, that's fine. I love the fact that you put your neck out there and answered the question. It's fantastic. Here's the deal. So remember, right? Generally speaking, the pain is generally more diffuse at the beginning over a larger area, but the pain may become more focused or narrowed down over time. Okay, if it begins to do that, and they say, yeah, you know, it was kind of a dull ache at first, but now it hurts right here, hurts right here in this one spot. Okay, that should increase your level of clinical suspicion for a stress fracture. Does that make sense? Okay, I'm going to take that to mean yes, maybe no. But here's the deal. Okay, when you take someone in, you know, if you're like, okay, well, let's get an x-ray, I'm worried about a stress fracture given your symptoms, you know, the x-ray might be negative, but if the x-ray is negative, but clinically they still have obviously signs of a stress fracture, it may be appropriate to go ahead and order an MRI for this individual. Could definitely be appropriate. You know, but generally speaking, if you see a stress fracture on an x-ray, generally it means that the injury is more advanced and it's been there for a while. Does that make sense? And you guys don't worry, this isn't like maybe the first time you're being exposed to this, but we will continue to revisit this concept as we go through the lower leg too. So don't freak out if you don't completely and totally get this right now. Okay, tarsal tunnel syndrome. That's kind of small, but okay. So tarsal tunnel syndrome is essentially a compressive neuropathy of the tibial nerve, okay, at the level of the ankle. So if you guys, you know, you don't have to do this, but if you were to take off your shoe and prop your foot up on your leg, right, what you would notice, okay, if you find your medial malleolus, you're going to notice a little groove, right, behind your medial malleolus, right, and right behind your medial malleolus, there's essentially this banded tissue called your flexor retinaculum. Okay, the calcaneus, the talus, and then the adductor hallucis essentially forms the floor of the tarsal tunnel. Okay, so we can see, and I'll try to show you here. Okay, so if you look, there's actually a nerve. This is not a very good picture, I apologize. But if you look at this picture on the right-hand side, you can see that there is a nerve that essentially passes through this tunnel, right? Right between between the muscles here, okay? So what they've actually done is they've actually kind of cut this retinaculum And so between the three tendons that we have on the medial side of the ankle, the tibialis posterior, the flexor digitorum, and the flexor hallucis, there's also a branch of the tibial nerve that runs through there that can actually become compressed due to essentially tendinopathy and or maybe even hypertrophy of the muscles or swelling. Okay, ultimately, if someone comes to you complaining of kind of burning at the medial foot, tingling numbness throughout the medial foot, that could be a sign of tarsal tunnel, right? And there's a test that we use for that called Tinel's sign, okay, which is where we essentially tap on the medial aspect of the ankle to see if we can, elicit tingling, numbness, burning by tapping there. Okay, that's called Tinel's sign. Don't worry, we'll learn that and go over that. But just a brief little introduction to tarsal tunnel. Okay, all right, hallux rigidus. Okay, so hallux rigidus. This is essentially progressive arthritis of the first MTP joint. Okay, so if you look at this picture down here at the bottom, okay, you can see how this individual has almost kind of lost a lot of the space. You see how we have a nice black line here, so to speak, between the metatarsal base, the first metatarsal base, and the first cuneiform. You see that? There's a nice line there. Okay, that line is much more absent here between the proximal phalanx and the head of the first metatarsal, right? At the MTP joint, right? So that's actually some arthritic change that we see there. All right, that's a loss of cartilage between those two bones and result in arthritis. So ultimately, with hallux rigidus, that patient's going to present with progressive stiffness and pain, basically at that joint. Okay. Where are we at? Sorry, guys, 1 second. It's 12 o'clock. We got plenty of time. Okay, guys, thus far, are there any questions? Let me actually stop sharing for a second. Are there any questions right now with anything that we've covered before we just knock out the last of this? Anything that's not clear? Okay, all right. Sorry, guys, 1 second. I realized I was missing a slide. I don't recommend writing exams and or prepping classes when you have a concussion because you forget stuff. And it makes you look kind of silly. All right. Sorry, guys, 1 sec. It's fixed. All right, who remembers, by the way, because we kind of talked about this kind of when we first started the foot and toes. Who remembers what turf toe is before we get into this last slide? Who can tell me who remembers what it is?
Isn't it hyper extension of the big toe?
Correct, hyperextension of the big toe. Now here's the deal. How does turf toe, right, generally present? Like, what's the patient going to be? How are they going to be tender? Or where are they going to hurt?
Like when they're walking, they don't like push off.
Okay.
They walk here. They walk left.
Okay. And so generally, right, with turf toe, all right, we're concerned about obviously sprain to the collateral ligaments of the MTP joint, right? With that injury. Now that's the turf toe, at least classically, is understood as a hyperextension injury. Conversely, okay, and this is, I honestly think this is more of an artificial distinction, but somebody decided to do this, and so I'm just going to roll with it. Soccer toe is really termed as more a hyperflexion injury, right, of the MTP joint with tenderness at the joint line. Okay, sorry guys. All right, show you. It's a good picture. Yeah.
Yes.
Sorry, guys, computer issues. All right. Okay, so obviously, guys, like we talked about, and I'll show you these pictures here in a second. So turf toe generally characterized as a hyperextension of the MTP joint, right? That results in ligamentous injury. All right. So people are obviously going to come in, complaining of pain at the first MTP joint, right? So generally speaking, generally happens when people try to push off. Generally when running, we actually see this a lot in running backs in football. So, obviously, we also talked about how there are also times where the joint capsule can actually also be injured, right? Resulting in kind of pain at the front of the toe. And also the extensor digitorum tendon. Awesome. Here we go, friends. Sorry about that. All right. So obviously turf toe. Okay. So we talked about obviously injury to the MTP joints of the toe. You guys probably can't see that actually. Need to shift. Yep. All right. Better. Okay. So if we look here, so obviously turf toe, okay, via hyperextension generally is how this happens. Now, we also talked about obviously in a lot of situations, particularly with more severe injuries or higher energy hyperextension or hyperflexion injuries, we can have injury to the joint capsule and also the extensor hallucis tendon, which is essentially the tendon of the big toe, right? Soccer toe is differentiated from turf toe due to obviously a hyperflexion mechanism. So, you know, I mean, turf toe can be treated via immobilization in a boot. If it's bad enough, lots of ice, right, and immobilization. So obviously we can use a turf toe tape job kind of in return to play, but we may have to use that in combination with essentially a steel-toed plate or basically a steel plate inside of a shoe as well in some patients. Have you guys seen those downstairs yet? I'm sure that I'm sure they have them. Has anybody had to use a steel toe a plate yet for a turf toe injury if you've had one yourself? Big fat no? Okay. All right. Okay. Well, guys, we did it. Okay, we did it. We have actually covered. Okay, we have covered the foot. Okay, chronic and acute pathologies. We did it. All right. Yay. So now we're going to be rolling through the ankle. Okay. It's going to be great. It's going to be fun times. So we will actually start.
Put that on Moodle?
Yes, ma'am, I will. I'm going to put this up on Moodle and the recorded lecture. Yeah, this will all be up. So, okay, it'll all be there for you. So don't worry. All right. How are clinicals going? You guys doing okay?
Yeah,
Busy week.
yeah, this week has been extremely busy.
Really?
Yes.
Yes.
Yeah. I noticed that yesterday when I came downstairs, you guys it was hopping in there. It's crazy.
Half that was because we're all in there at the same time doing
Yeah.
nothing. There's
Yeah.
nobody.
Also,
I mean, it
at the same time,
sounds-
so.
Yeah. It's only gonna get worse in April.
Yeah.
Yeah, but then someone's
Well,
gonna be going
one
outside.
is coming out at the same time.
Yeah.
Early, I'm gonna come in just to get my ankle taped by you.
Good.
Right.
I
Yeah,
know.
well, So it's kind of crazy. You guys actually, I don't know what's going to happen, but with Troy out, you guys might actually get to see me be an athletic trainer, which might be kind of weird for you. Because you guys only see me teach.
That's
I get a new
That's
preceptor if we
crazy.
get late.
Wait, that means you're gonna see me at practice.
Yeah, I don't, you know, if I get asked to help, I don't know obviously where they're going to have me help, but they may.
Well, if you're filling in for Troy, you'd be with football.
Theoretically, yeah,
Football
we'll
and
see.
track.
So
Does that mean
Yeah.
I gotta bring this?
anyway,
So do I.
but I don't know yet, guys. I mean, they have to obviously tell me if they need me first and foremost. But anyway, you guys are great. All right, thank you so much for sticking with me, even in the midst of my craziness. I really appreciate it, guys. I appreciate you guys bearing with me. So I will see you guys tomorrow. Okay, Kaya, you and I have an appointment at 5 tomorrow. Sweetness.
Right here.
Right here. You got it. Well, not here, but there.
Right here.
Yeah, right there. You got it. All right. Hey, you guys have a great day. All right. And I'll see you tomorrow.
Bye, Wade.
Bye, guys. See ya.
See you tomorrow.
Bye.